One of the hardest parts of brain injury recovery is trying to find out the root cause of where your symptoms are coming from. In today's episode, we are going to look at one of the possibilities for this, which is neck injuries, joined by Dr. Sasha Blaskovich. There is always hope, and you are not alone.
Hi, I'm Cristabelle Braden, and this is my brain injury podcast, Hope Survives. Here we share information, education, and support for the brain injury community. This is an uplifting podcast to bring hope to your darkest days. As a survivor of traumatic brain injury and multiple concussions, I know what it's like to struggle to find hope. I don't want anyone to feel as alone as I did. And that's why I started my online community called Hope After Head Injury. This podcast is an extension of that, and I'd love to invite you to join along as we explore the realities of life with brain injury, with messages of encouragement, interviews with doctors and professionals, and survivor stories. No matter where you're at on your journey, there is always hope.
With a little hope, you can make it through today. With a little faith, someday you'll get through the pain. Just a little love is enough to light the way through your darkest night. Hope survives. A little faith, a little love. Hope survives.
Hello, friends. Welcome back to another episode of Hope Survives podcast. Today's episode is very, very interesting. Dr. Sasha Blaskovich, who also is known as Dr. B, he shares his journey into chiropractic care, actually originating from his own sports injuries and how that eventually led him into focusing on concussions and brain injuries and finding out that neck instability can actually be a source of brain injury symptoms. Now, it's really fascinating to learn this because so many of us are on this constant search of trying to figure out what precisely is going on. But remember, brain injury symptoms are usually never originating from one thing. A couple episodes back, we had Natasha Wilch on the podcast. We had an episode called Making Sense of the Messy. And in that episode, we talked about how, especially if you have chronic symptoms, it's probably not just coming from one thing at this point. But it is helpful to try and figure out what the source of the symptoms could possibly be. In my own journey, figuring out that there were some headaches originating from the neck was instrumental in helping my neck, helping my headaches to improve. But he kind of takes it a step further, and you'll hear our conversation. And he shares things that I actually have never heard before, which is really, really intriguing. And so there's something called a motion x-ray. That's a diagnostic tool that he's going to talk about. But before we get into the interview, I first want to just address our survivors. Number one, do not get overwhelmed by all of the information that is coming at you from this episode. I highly recommend going to the transcription section. If you listen on Apple Podcasts or on Spotify, they have automatic transcriptions that you can follow along with or read. And on YouTube, if you're watching this, you can turn on the captions. That might help you to follow along with some of the vocabulary and some of the medical stuff that is shared. And also remember that this could possibly be one of the sources of your symptoms, but please do not be discouraged if you think maybe it doesn't apply to you. There are so many different sources of new research, and this is just one perspective and one avenue to search. So I highly recommend listening. And if anything, it can bring you hope on how far technology has come and that there are amazing providers like Dr. Blaskovich out there doing research, treating patients, and figuring out sources of symptoms for survivors. So, all that being said, thank you so much for listening to Hope Survives podcast. I'm so glad you're here. Please join our Zoom support groups. We meet once a month. hopeafterhenry.com/community. I also run a Zoom brain injury Bible study. Would love to see you at either of those Zoom meetings. And remember, there's always hope. So let's get into the interview. Today, I am so excited to welcome Dr. Sasha Blaskovich to the podcast, but he told me his patients often call him Dr. B, so that's probably what I'll be calling you today. Welcome to Hope Survives podcast. Thank you so much for being part of this.
Thank you so much for having me. Appreciate the opportunity.
Yeah, I'm really looking forward to what you have to share. So, before we get into our conversation, can you go ahead and introduce yourself and share a little bit of your background and what you got you into working with patients with brain injury and concussion?
Sure. Yeah. So my name is Dr. Sasha Blaskovich, and as you said, generally referred to as Dr. B for the ease of not having to butcher my last name. But I'm a board certified chiropractor in 3 countries, so the US, Canada, and in Europe and the Netherlands. And I came into this profession from a very young age. At 12 years old, I knew I wanted to be a chiropractor because of a hip issue that I was having. And the only help that I got after 2 years of searching and being told that I can't really play sports was a chiropractor, and got me back on track. And I was just mesmerized by the bedside manner, the excitement, the ability to diagnose and just not be very superficial with the work. And so at that point in time, I thought, yeah, I want to do what this guy does. And so I went in that direction. In university, I played football and I suffered a concussion, or what was diagnosed as a concussion there. And that's kind of what changed things. When I went to chiro school, it was about 2 years after my concussion, and I started developing the usual impairments, if you will, as a result of being, I guess, less active, because chiro school is literally a 24/7 job. It's a way of life. It's no longer like university where you play most of the time and only buckle down for a couple hours a day. And so that's posturing that I had to have there, and the lack of, I guess, movement and exercise brought out my symptoms. And so I started noticing all the usual post-concussive symptoms. And thankfully, I was in chiropractic school, which gives us a great platform to learn, but also they teach us how to learn about stuff that's not in a curricular textbook somewhere. So how to dig through research, how to investigate little concepts and take a tangent and learn more about something, and then piece it all back together into a concise and coherent story, or a concise and coherent entity. And that's kind of what brings us to today. For the last 24 years, well, for the last 30 years, but specifically for the last 24 years, I've been doing exactly that and trying to piece together all the different aspects of this phenomenon, if you will. Let's call it MTBI, concussion, TBI, whatever we're going to call it. There are so many components to it that require knowledge, or at least some prowess, in to be able to, diagnose properly, and then, to follow that up with proper treatment, from the anatomy, the physiology, the chemistry, the biology, the neurology, the radiology, and then obviously you get into the therapeutics, and all those things pieced together usually provide a much more coherent means of pointing someone in the right direction, not necessarily being able to fix each and every one of them, but at least knowing when to try what you can try, and then knowing when to refer out for adjunct therapies and/or whatever else needs to be done, so that the patients get put into the right path, so that they're not struggling like most people do for years to decades without any, solid answers, and just a whole lot of trying and nothing really sticking.
That's such a good way to put it. Thank you so much for sharing your background. I feel like so many of our listeners or members of my support groups, they're always struggling to put the pieces together and to be able to figure out what is going on and why their symptoms are lasting so long. And I think you did a really good job of describing that. So with your own concussion, what was your experience like in getting through that? And moving forward into working with patients with concussions?
So yeah, I guess the most relevant thing would be that the sort of long lasting component of the vast majority of us can either come from one of two things. And one would be, actual trauma to the brain where there's at some microscopic level damage that, lo and behold is not visible until you get to the stage of what, has been deemed, CTE or some other, demyelinating condition such as MS or whatever else that could potentially at some point in time get diagnosed. In the initial phases of that could be part of the reason is that there is a underlying low grade microscopic damage that takes, years to decades to finally fester to the point of being visible. Or the alternative, which I'm finding a lot more evidence of clinically as the years go by to some degree of severity, is that with these traumatic causes for MTBI or TBI, where there's no visible change to the brain matter on an MRI or a CT scan with contrast, is that a lot of these patients, if not the vast majority of them, have evidence of damage to ligaments in their upper neck. And so what that means is our bones are held together by fibrous connective tissue that has very little to no elasticity, but allows for some minute amount of movement. And these are ligaments. They're literally ropes that bind all of our bones together in our body. If you remove all the muscles, we still don't fall apart. Now, those fibrous connective tissues, when stretched or partially torn or completely torn, remain so. So if they get stretched, they no longer recoil back to whatever their resting length was to continue to provide integrity for that joint. So what that means is that joint now has extra play or extra movement in it. Not as big of a deal in the knee, for example, because eventually the likelihood that it could become arthritic is there, but it's not going to affect any neurology. When this happens between the top two vertebrae in your neck and you have excess play or a little bit too much play there, they could, by that excess movement, irritate your brainstem, resulting in the chronic cascade and recurrent cascade of MTBI-like symptoms, which we deem post-concussive or chronic post-concussive syndrome. And in essence, the origin of those post-concussive symptoms is not directly coming from the brain. It's directly coming from compressive irritation of the brainstem. Sorry about that. Compressive irritation of the brainstem, resulting in mild to moderate backpooling of fluid into the brain because it's not able to drain as freely when there's an encumbrance at the junction between the skull and the neck. And so it pulls back into the brain, causing mild compressive forces, hydrostatic compressive forces inside the skull, which then render a lot of the brain tissue or certain parts of the brain tissue not as properly functional.
Wow.
And so this has been sort of the missing link that we've been seeing more and more and more, again, to different degrees of severity clinically when we're looking for it. And so that's sort of a take-home message that I'd like to get out there as much as possible, is that when brain injury is suspected, whether mild traumatic or traumatic, and it's not visible on scans, and whenever conventional therapies are being utilized to try to combat and return somebody back to a baseline are not being effective or helpful, at least not lastingly, there should raise a suspicion for, is there damage to the ligaments of the upper neck resulting in this hypermobility of that region, resulting in irritation of the brainstem and mild compressive forces of the drainage tubes that should drain the brain fluid down through the spinal canal, allowing it to be reabsorbed, whereby it's backpooling slightly and causing compressive forces from within the skull just from the accumulation of extra fluid on a small scale level.
Wow, that's so interesting. Thank you so much for explaining that.
My pleasure.
I feel as though so many people, you mentioned a phrase, chronic cascade of symptoms. And so I don't know I don't know where everyone listening to this is at, but I know for me that has definitely been something that I've experienced and that so many people who've had brain injuries do experience. And so what kind of symptoms could come from this type of neck I don't know what you'd call it, dysfunction, injury,
Yeah, I call it instability. When it becomes
instability. Okay.
it's hypermobility if it's moving too much. which is there's a fine line between that and when you start getting clinical symptoms that are neurologic in nature, then I would deem it instability once you've seen it on the gold standard for assessing that is motion x-ray, where a person moves their neck around in all the different planes of motion and you view how the bones move in relation to each other. And if you see excessive motion and they have neurological symptoms, then I would clinically deem that leaning towards instability instead of hypermobility. And anyways, the vast majority of symptoms, that people will talk about go anywhere from the obvious, so headaches and neck pain is usually the base of the skull. They will then have dizziness, nausea, vertigo, not all of these, but any group of these. So dizziness, nausea, vertigo, heart palpitations, blurry vision, fullness in their ears, ringing in their ears, temperature control issues where they have hot flashes, cold shivers, urinary urgency when they're not fully hydrated, diarrhea, constipation, acid reflux, balance and coordination issues, fine motor issues, memory and cognitive issues, irritability and anger. All the typical concussive-like symptoms can arise from this. And they're not always the same, unfortunately. Sometimes people will talk about having dizziness and nausea and blurry vision. Other times they'll talk about heart palpitations and they'll have hot flashes or temperature control issues, excessive sweating. So because it's not a constant and repetitive cascade of symptoms, it makes it really difficult clinically for physicians to say, this is what I think it is. So they'll generalize. And if it took me quite a while to hone in on what I think is the reason why the symptoms vary. Sometimes they're, like I said, a certain cluster, and other times they're a different cluster. And the reason is that instability at C1, C2 affects the lower part of the brainstem, which is called the medulla oblongata. And one of the most important structures that branches off of that part of the brainstem is the vagus nerve. And if you just Google the responsibility of the vagus nerve, so it's a background parasympathetic nerve that's responsible for rest and digest. So all of our background baseline bodily functions are under control of the vagus nerve. And it becomes the vagus nerve not at the brainstem. It becomes the vagus nerve past that when it actually exits. Where it actually exits the brainstem, there's different roots that all together eventually funnel into what would be then deemed the vagus nerve. But because these roots all have different origins along the brainstem, if these roots get compressed, you'll have a certain cascade of symptoms. If these roots get compressed or irritated, you'll have a different cascade of symptoms. Whereas when you compress the vagus nerve after it's already exited, you could have all of them.
Okay. Wow. Thank you for explaining
And so when patients are complaining about heart palpitations, respiratory issues, stomach acid, balance and coordination, those are totally different systems within the body. And for them to all at the same time have a misfire or a malfunction, it's really hard. It's not impossible, but it's virtually impossible for those problems to literally originate in that system. So the heart is failing, the lungs are failing, the urinary tract is failing, the digestive tract is failing at the same time. So one would have to suspect, well, what ties all of these things together and what connects to all of those different systems in a background sense is the vagus nerve.
That's so interesting. I feel like so many people with concussions or different types of brain injuries experience a lot of these things, but this is the first time that I've ever heard somebody say like the respiratory. I've heard the gut being attached to the brain and having issues like with gut, especially with the rest and digest, as well as I have two questions for you. Okay, sorry. I'm just like
sorry about the phone here.
No worries. So okay, my first question is, I have had a lot of respiratory issues but I always thought it was just allergies and asthma. So it's like how so many people with concussions could have issues with all these different areas, but how would you be able to know, is it just allergies and asthma, or if you're having all of those other things as well, could it be from this? And how can you figure that out? That's my first question. My second question, I don't know if you can answer them together, but a lot of people get diagnosed with dysautonomia following a brain injury. I'm one of those people. So when you say heart palpitations, I have often had that happen, but it's been in combination with what I have perceived to be the low blood pressure with the dysautonomia, and going from seated to standing too fast and things like that. But could that all be related? How does dysautonomia play into this? So sorry, two separate questions, but I don't know if you can
repeat Just repeat the first question if you would mind.
Yeah, I'm so sorry. I'm just like, my brain is like spinning. So the first question is, people who have a lot of concussion symptoms and brain injury symptoms, they might be also having gut issues, but I've never heard respiratory also be explained. So how can you tell the difference? Is it just allergies and asthma, or could it be from your brain injury?
Yeah, so it could be allergies and asthma, but however, if you look at everything in our body, no matter what it is, somehow is linked to the nervous system. And so
Hmm.
the nervous system ultimately has the ultimate control over everything, both sensing pathogens or allergens or whatever else, and then providing an adequate immune response or adequate whatever response through the nervous system to combat that. And so, because the nervous system is responsible for that, you have to, at least at some point in time, when you've gone through the whole chemical, trying medicines for this, trying to either suppress the immune system or support the immune system, and you're not getting anywhere, there could be a likelihood that somewhere in the nervous system, there's a misfire or a miscue at the wrong time, or possibly an excessive cue at the right time, causing this cascade of abnormal or unacceptable symptoms to occur. And so the vagus nerve, again, I mean, if you look at its responsibility in vascular diameter, so it can determine whether you vasoconstrict or vasodilate. It can also affect the immune system. So the release of eosinophils, the white blood cells, whatever, in response to whatever the pathogen or allergen could be. And so the control over all those background systems. So I talk about rest and digest, but in there is immunity, allergy, resistance, all of that stuff. And I didn't even get into certain symptoms that most of us, myself included, on a daily basis have to deal with. And that, for me, the most prevalent one from the day that I had my injury is, to this day, fullness in my ears. I feel like I'm always going up in an airplane, having to recalibrate my pressure between my inner ear and my head. And also chronic postnasal drip, sinus backup, hoarseness of the voice is a common one. Sometimes people also have difficulty swallowing, or constant, they'll snore, they'll have sleep apnea, all of these things. And like you said, your heart rate changes when you go from seated to standing or laying to sitting. And so that gets diagnosed as POTS. And dysautonomia and POTS are two diagnoses that don't really tell you a diagnosis. They literally describe your symptoms.
Yeah, that's
And
so
so
true.
getting the diagnosis of POTS doesn't really tell you what it is. Everyone's happy because it's been labeled with a term, but what exactly is POTS? It's telling you that, it's postural orthostatic tachycardia syndrome. And so syndrome is just a cluster of symptoms. Tachycardia tells you that your heart races, and PO, that means that when you change position, this all happens. And dysautonomia is the same thing. That's probably sort of a more elaborate version of POTS, because POTS would be a part of dysautonomia. And it just
Mhm.
tells you that your autonomic nervous system, because you're experiencing autonomic-like symptoms, is somehow misfiring or malworking. And so when I tie back to what I was just explained earlier with the vagus nerve and all its interconnectivity and interrelationships that it has with all the different organ systems, it would pose to make some more sense, or a lot of sense, that could be the missing link. And so, you have different techniques to reset vagal tone, which means at that moment how the vagus nerve is transmitting information. And when that works only in a temporary fashion, then one would again have to try to raise the suspicion of, is there a mechanical compression or mechanical irritation to some component of my vagus nerve, whereby my vagal tone reset, whether it's breathing, cold water exposure, mindfulness, meditation, whatever it is, only gives me a temporary refractory time where it feels like things are better, and then it gets worse again. And I would
Yeah.
propose and postulate the reason that it gets worse again in a relatively, inopportune amount of time is because there is some level of background mild mechanical irritation of the vagus nerve, or that part of the brainstem where the vagus nerve branches out of, by an excessively moving C1 or atlas bone.
That's so interesting. Thank you so much for explaining that. So you mentioned a motion X-ray as a
Yeah,
diagnostic tool for this. Can you talk
I
a
did.
little bit more about that and how that works and how it would benefit people who've had brain injuries and concussions?
Sure. So when you want to assess for the integrity of motion, you want to do that in real time. So all of our bones in our body have what would be deemed a allowable amount of micro motion. And when you combine that all together, you have this global amount of mobility that we all portray and display on a daily basis, but that's all broken down into small components. And so by doing motion x-ray, you're literally taking specifically in this case, the neck, you're taking them through flexion and extension movement while you're real-time video x-raying them with fluoroscopy. And you then go side to side bending with the open mouth because you want to look at the C1, C2, which is the most important part of this exam. And then you've got obviously the rotational component as well. So you got flexion, extension, side to side, so lateral bending, and then rotational movements. And in order to assess any anatomic object in 3 dimensions, you have to incorporate all the 3 cardinal planes of motion. Unfortunately, in mainstream medicine, the only cardinal plane of motion that is assessed in what they constitute or call dynamic imaging is flexion and extension. And they'll only do that in a static endpoint. So they'll do a static endpoint, take a picture, put you in neutral, take a picture, and put you in extension to take a picture. And then they assume that whatever they see there is going to deem your neck either stable or unstable. And I would postulate that 99% of the time it's deemed stable because the only thing they're looking for is what's called the ADI, atlantodental interval increasing in flexion. And when that doesn't happen, they say, okay, the neck is perfectly stable. However, when you do side to side bending and rotation, you see other things that are extremely relevant and can extremely easily explain the cascade of symptoms the patients are dealing with that you can't see otherwise, either in static motion or static positioning, or without even conducting that. And so the 3 cardinal planes of movement need to be assessed in real-time motion. And when you do that, you can determine where people have areas of excessive motion. And for example, if they have excessive motion in a particular spot, where they're also complaining of neurological symptoms then you can basically say, okay, we're seeing the excess motion here. You're complaining about these neurological symptoms. Those must go together. It's really hard to say that can't be connected. Nothing is a perfect science, but it definitely gives you a much higher probability of honing in on exactly what's causing their symptoms and then being able to then come up with a game plan as to how to mitigate that properly from least invasive to most invasive.
Yeah, thank you so much for sharing. And so
Ultimately, if you want to see, so this is what it looks like.
Oh, okay. So
it's
for
got a
those
workstation
watching the
and then it's got
podcast on YouTube, you can see it. If you're just listening to it, can you describe what it looks like?
Oh, sorry. Yeah. So it's basically in the shape of a C. It's called a C arm. And a lot of hospitals have these for procedural purposes. So when they're doing either biopsies or doing nerve blocks or trying to get into some places to put in prosthetic joints or whatever else, they'll use this so they can watch real time what they're doing, and it helps them do their job better. And so, but they're not really concerned about diagnostics. It's more of a procedural device. And so the same type of C-arm can get modified from a hardware and a software standpoint to then be used for diagnostic purposes as opposed to just for surgical procedural purposes, where you can actually get this information. And because it's such low radiation, you can do real-time video for the same amount of radiation as just a few regular x-rays. So it's very nominal as far as how much exposure the patient and the doctor gets when using this.
Yeah, thank you for sharing. So I guess what everyone's going to be wondering is how could they get this assessment? And then the next question is, I know this is probably hard to generalize, but if you find out somebody has this issue, how do you treat it?
Well, like I said, from least invasive to most invasive. And so least invasive would be addressing what I call the neuromuscular reset. So all of our muscles in our body are wired to protect areas where there's excessive movement, whether that's the knee joint. People who've injured their ACL in their knee, they perpetually understand that their calf is tight, their hamstring is tight, and their quad muscle is tight on that side because it's compensating for a loose joint. So the muscles actually undergo what would be a altered resting tone to be able to accommodate and try to basically make up for what the ligament is not, or ligaments are not doing after they've been injured. And so in the upper neck, there are a whole bunch of small little intrinsic muscles that are 5 to 6 layers deep from superficial inward that are responsible for sensing these excessive movements and then mitigate or controlling them back to a neutral baseline. And those muscles do that really well, but they can't do it really well for any indefinite period of time. So they will actually work themselves into a lockdown state. Just like a calf will cramp when you try to do excessive training for running, these muscles will not cramp, but they'll seize because they're short, little tiny muscles. And so they don't usually feel like a cramp. It just feels like rigidity and like you can't move as much. And so people like myself, a chiropractor, or people in my profession like chiropractors or physiotherapists or anybody else who's doing manual medicine will perceive that as a stuck joint and will unfortunately occasionally try to manipulate that joint loose. But the actual problem with that joint is not that it's too loose. The underlying problem is that it's actually that it's too tight. The underlying problem is actually that it's too loose. And then this muscle rigidity that happens when the muscles have been overworked and they lock down to both protect themselves and protect what they're connecting to, you get into this cascade of compressive forces on the brainstem. And so by just pressing on those muscles and holding for a substantial amount of time, you can actually get the muscles to release and go back into a functional state where they can control that excessive movement quite well. But again, they will repeatedly fail. And so I've been doing this to myself for the last 24 years, and it does repeatedly give me the reset where I can function at a relatively normal keel most of the day. But inevitably, I have to repeat that procedure on myself multiple times a day. I had a little setback 5 years ago where I have to do it much more than I did prior to that because I've been dealing with this problem for 30 years. But at any rate, I still have to do it on a daily basis. And so that's the least invasive and the easiest to both have done and then learn how to implement on yourself. And the second phase of that would be to try to do something that's going to either scar up or shorten up the collagen matrix in those damaged ligaments. And that would be some form of regenerative injection medicine. So prolotherapy, platelet-rich plasma, or stem cells. But with all those, you always also need, and same with what I just said with the neuromuscular reset, you need to see real time in the motion x-ray exactly where the instabilities are so that you address the musculature that would be responsible for those areas of instability, not everything. So it actually turns the treatment into less is more. So you actually end up rendering less treatment, but it's focal to where you saw the instability and you get better results. And the same thing with the regenerative injections. You need to know exactly where those instabilities are so that those needles can be implemented in the exact spots where they're needed and not just generically everywhere and see what happens. And then if people have done that and it's either not helped or they can't come to grounds with the fact that both the neuromuscular reset and the regenerative medicine injections will need to be repeated. So the neuromuscular reset, obviously daily, but the regenerative injections potentially in 3 months or 6 months or at some point in time. And then with the expense of those therapies, especially the regenerative medicine therapies, sometimes it's not feasible. And so then the end stage of that, again, would need motion x-ray to determine exactly where the instability is and how bad it is, would be fusion surgery. So that's kind of the end game, is basically saying, okay, there's too much movement here. We're going to turn it into no movement by doing, putting in surgical screws and then you're done. But unfortunately, it's rare that somebody only has an injury on one spot. So if you just fuse one spot, occasionally there's this phenomenon called the adjacent segment syndrome, where when you fuse one spot, the next spot that was also kind of unstable becomes slowly more unstable because now you've taken that sort of global instability and taken one and stabilized it. Now you've got a little bit more vectors and forces on the spots adjacent to it, which then with time and use rattle loose faster than they would normally.
Wow.
But all this can be, minimized with the proper assessment. So I'm kind of giving you the doom and gloom worst case scenario, but, can be, quite scientifically done if addressed from this standpoint and done in a fashion that's not, let's just try this stuff and see what sticks.
Hmm.
I'm a firm believer that diagnostic imaging should be the gold standard. So when people contact me from wherever, from Nigeria, from Tasmania, from Australia, from the States, Canada, wherever, the number one thing I want to see is all of their imaging. I don't care to read their reports on the imaging because 9 times out of 10, what I'm looking for on their imaging has not even been looked at by the radiologist who wrote the report. So they'll get a report that says unremarkable or normal for age or whatever else. But then when I look at the imaging, I see little nuggets, especially in their upper cervical spine, that tell me that they likely have instability.
Yeah, thank you. So how would somebody go about getting this done, like this diagnostic test? And then have you seen patients improve with their concussion and brain injury symptoms from addressing this issue in the neck?
Absolutely. Again, if you know what you're addressing, then it makes the addressing that much easier. And for this subgroup of patients, for example, most people eventually go into getting some kind of vestibular therapy. So that's a really common, both getting referred to an ears, nose, and throat doctor who says, I don't see anything wrong. And then they'll get referred for vestibular therapy, which oftentimes, if not all the time, makes them worse. It makes them more symptomatic no matter how much it's tried. And so that should, again, pose the question, is there something going on in the upper cervical spine? And so when you know all that stuff, the improvements are exponential and really good, especially when the patient is willing to learn how to, first off, learn the ins and outs of this pathology, and secondarily, be willing to learn and implement these self therapies on themselves, especially the neuromuscular one. Because I have seen patients that were bedridden and really bought into this and really went and wanted to understand it and really said, I'm going to do this, to the best of my ability, that literally regain their life. And then there's other patients who just can't see to wrap their brain around the fact that they're going to have to, push on certain muscles in their neck 10, 15, 20 times a day just to get a relief of the symptoms temporarily, only to have to do it again. So for me, the way it happened is nobody sat me down and said, you're going to have to do this 10, 15, 20 times a day to try to maintain some level of normal balance in your life. I just did it instinctually because it got me through the day. And then I started then going, backpedaling and researching as to why is this effective? And then secondarily, and most importantly, why is the effect not lasting? Like, why do I need to repeat it? That was the most important epiphany that I had, was why it recurs. So the effect of being beneficial is great, but I think the biggest sort of slap in the face for anybody that's going through this when they have a benefit is, well, why does it not last? Because we're so used to any kind of therapy. You have a kidney stone, you go through the therapy and the kidney stone passes and you're good to go again. Whereas with this ligament damage, it's a permanent deformity. It never actually regains its stability again. And so the way the body reacts to it is through this neuromuscular loop that is resettable indefinitely. And I'm living proof for 24 years now that you can reset that neuromuscular loop so that it functions optimally for a period of time, only to have to repeat it. And again, because
but you have to learn how to
said,
recognize when it's being unstable once you start,
correct.
right? So
correct. I always tell people it's rarely a matter that it's painful and I'm going to go do it. It's usually something like, I feel like I'm more off balance. I'm lightheaded. My vision is a bit blurry. My heart, I feel like it's racing a little bit. I'm a little bit more sweaty, if you will. And I haven't done anything to trigger that. So I haven't done anything to make my heart race. I haven't done anything to, get myself that cold sweat. I know it's coming from my vagus nerve, and I've trained myself to perceive that. So like, okay, now I'm going to go press on these muscles. And like I said, 9 times out of 10, that neurological subtle cascade of symptoms just completely goes away.
Yeah.
Only to potentially resurface a couple hours later, but at least I know how to get it to go away. And like I said, I morphed into it by doing it because it gave me a temporary relief and it could get me through the day. And then I, backpedaled and tried to figure out, well, why is this happening? And so I believe I figured that out. And it's very enlightening to know that, and also know that it can repeatedly be done so far indefinitely without having to, undergo those different pathways of more invasive therapy, if you will.
Yeah. So if somebody's listening to this and they're thinking that they can relate to it, or they would like to find out if this is an issue for them, where do they go? How would they go about getting this diagnostic testing done?
Probably the best way, you could Google motion x-ray or whatever else and see if there's somebody close by. There's not a lot of us. There's a few scattered through the States. There's only 2 in Canada. I don't know of any in Europe, to be honest with you, as far as that are being used for this. And so it would be a matter of Googling that, or even just reaching out to me either through the best way for people from a further distance away is to just go to drblaskovich.com. So that's drblaskovich.com. And there's probably there is a contact form on there where they can reach out, and I can try to, point them in the right direction. And if that's something they want me to try to help them with, I do have a virtual capacity to do that, which would require for them to somehow share all of the imaging that they've had done already for the particular problem with me, so that I can basically look at that imaging. And what I would then do is screenshot any abnormalities that I see, and then annotate them as to what the abnormality is. And then I would share that with them on a Zoom call like this and explain it to them. and then hopefully point them in the right direction and try to find either somebody locally or help them with information that a local person could use to try certain modalities of treatment on them that they probably haven't tried yet. And then for local people, they'll try to find me at whiplashclinic.com.
Okay.
And that's just but just whiplashclinic.com. And there's contact forms on there as well.
All right. That's so interesting. Thank you so much for sharing all of this. It's enlightening to
pleasure.
me, and I wasn't even fully expecting that. But when you mentioned like the respiratory stuff, I'm a singer, and when I was studying voice in college, I was dealing with a lot of concussions and a lot of constant concussion symptoms, and I was losing my voice all the time from postnasal drip. My vocal teacher thought I might have had a nodule, so I went to an ENT and they did a scope and they said, "No, you're completely healthy. It's just extremely inflamed." They did allergy testing, found out I'm allergic to a bunch of stuff. They tried me on allergy shots. I eventually stopped taking those. But I have never heard anyone relate that to the brain injury, to the TBI.
Yeah.
So I'm very interested in figuring out, wow, that's really
It is
interesting.
fascinating. Yeah. I wanted to sort of get this out. So in 2019, I actually wrote a book that was published in 2019. It's called Dr. B's Concussion Breakthrough.
Okay.
And it explains this connection between the upper neck and this sort of concussive phenomenon, this global concussive diagnosis phenomenon, and how, the upper neck can and often does play a crucial role in that whole pathology. And that's on Amazon, Dr. B's Concussion
Okay.
Breakthrough.
Thank you. I appreciate
My
that. And I'm
pleasure.
sure people will be looking that up. I'm going to look into it. Before we go, our last thing, I always ask our guests, this is Hope Survives podcast. So I ask, what are your words of hope for our listeners?
There's always hope. I mean, whenever people come and say, we've tried everything, everything's been done already, I can guarantee it hasn't. And there's always hope, and that is that there's always another opinion to obtain out there that might be the opinion that you're finally been waiting for a long time, that'll actually get you on the right path to regaining your life back.
Thank you so much. We really
My
appreciate you
pleasure.
coming on and sharing. So if people want to get in touch with you, just the way you mentioned through your website would be the best way.
That's probably the easiest. Yeah.
Okay. Thank you so much. We really appreciate
pleasure.
you. And this has been very informative.
Thanks for having me.
Thanks so much for tuning in to Hope Survives podcast. Make sure to subscribe and stay tuned, and would love for you to consider leaving us a rating or a review. Check out hopeafterheadinjury.com for more. I'll see you next time. And remember, there's always hope.